First cases mostly connected with the wet market in Wuhan. As of February 6th, roughly 30,000. As of February 11th, today, there are 42,000. And of that 42,000, 30,000 were in Hubei province in Wuhan. There were 216 cases outside of China then, of which 2/3 were in Asia. Now there are 300 odd, and the same proportion are in Asia. The number outside Asia is boosted by all of the people on a certain boat, which has a substantial number of cases, and we don't know the quality of the diagnosis, but we do know that there are deaths occurring on this liner. So at the time I wrote this, the case fatality was roughly 2%, much lower than SARS. In fact, right now it's 42,000 cases and 1,000 deaths, which means 2.5%. So we hope it's going to stay that low. There may be more cases as more cases go on to get the more serious, lower respiratory infection later on in the course of their experience. This is the way it has spread so far. This again is an old slide as of February 6th, but it obviously had gone a long ways to a lot of different people. But there haven't been any new countries since then, still the same countries. And what Wuhan has done is had a really hard job of trying to cope because no hospitals were available to handle that many people. And these people were, needless to say, really sick. And I'm sure you all read about Dr. Lee, who was one of the ones that blew the whistle on the outbreak when it first started. And he unfortunately was called in on a bureaucratic task to answer questions and sign something, and he says he didn't really see what he said he saw. And then subsequently he died of the disease. This is what the outbreak looked at. This is from a New England Journal paper that came out probably around the 1st of January 20th, I think. It's the 25th, 26th, so you can see it goes up through January 20th. And the notable thing about this is that the dark orange bars are people who actually had exposure to the wet market. The others are all person-to-person exposure in the city. And these were the distribution of the cases. They distinguish between wet market exposure and contact with another person with respiratory symptoms. But I don't think these two items here are very carefully distinguished because obviously they're working under a lot of pressure. One of the responses in Wuhan was to set up this sort of thing, basically an armory that took care of the people in the 1918 flu with beds for everybody who was worried. So this is where they sent the worried well. I wonder whether or not some of the worried well were actually not well and may have caused other of the worried to be not well. So we don't know whether or not there were actually aided in the transmission by setting up these, I don't know what you call them, holding bars, I guess, holding pens. The holding pen, which included people who didn't think they were sick with somebody who did. Okay, so what's happened outside China? Well, multinational tourists on an ocean liner parked off the Japanese coast and then transmission in other countries. This is a slide that was recently released by WHO. It's basically a slide which categorizes all the cases according to their date of reporting, and it gives their exposure history. And you can see the blue cells on the right represent the cases that were on that ocean liner sitting off the Japanese coast. And then there are a few pink ones which say no travel. I don't know exactly what that means, but I presume it to mean people who were infected by contact with a case in a non-Chinese country. Although some of them are, there's a green bar for people who are exposed to countries other than China. This is the more relevant slide because it shows the cases by day of first symptom of all the people outside all the people outside China. And again, there's those same pink bars. And if we had those lined up, we could see that there would be an epidemic curve of people who were exposed outside. But until we know more about those people, it's pretty hard to interpret it. But I take this to mean that there's not a great deal of most cases being caused outside of China. And I hope that's true. This is a picture of the ocean liner off Nagasaki, I think it is. And here's a history which apparently is wrong, but it's right in certain respects. This is a German person who went to Wuhan, came home to Germany, had positive diagnosis, and then these two people who were his business associates, I don't know what business they were in, I presume it wasn't professional wrestling, which means that they probably were fairly distinct from him, but they were infected and they have popped up. But these are the states in which there have been cases showed up from Wuhan in America, and there's been at least one transmission from man to wife in Chicago from a case, again, fairly intimate exposure. And there are lots of people under investigation, but only one out of that bottom number has proved positive. So there have been 12 cases in the United States. This is, I think, the most informative thing, and it was done by the doctors in Singapore. So Singapore is actually the place where the most cases outside of China have occurred, and there are now 47. And you can see how the curve is increased from day to day, and it is very small jumps, and it has taken a week or so to go from 30s to 47, and most of those 47 are people who were still exposed in China. Among the total in Singapore, there are 20 odd that were not exposed in China, but some of those, but it's still not clear where their exposure came. But certainly some people have been exposed while in Singapore, and at least a few of them were not intimately associated with previous cases. So they still has to be looked at in more detail. And if you actually look at the complete data, this is the number of cases with a known travel history to China and the total number with possible or confirmed transmission outside of China and the total cases under investigation. But if you go down this list and look at all the stars very carefully, you'll see that they're really outside of Asia. There are only about 9 or 10 cases that have occurred that occurred because of exposure to a case, not because they actually were exposed in China. 5 of these were in France, and the one in the one I mentioned in Chicago, and a few others. So basically, we have to wait and see what happens as time goes on. And this I find also interesting. This is the cases according to Chinese province. And this 32,000 in Hubei province is just amazing to me. But you notice that there are 3 provinces with at least 1,000, and then a couple more with 800 and 900. And if you look at the map of where these people are, this is Hubei province, and that river is the river that Wuhan is on. And the other places with 1,000 were Zhejiang, Guangdong, and Henan. So these are all very reasonably close. And then there are a few in the about 500 in each of these others. So I'm positively affected by the fact that there really isn't a huge number of cases in places other than Hubei province. And that means to me that it's likely that the authorities in each of those places are going to be able to look after things, and things will settle down. But I don't know for sure. So basically the question is will it be a global pandemic? Is it as serious as SARS? Well, we already know that the case fatality rate is much lower than SARS. And the question is whether it will be a global pandemic. And I tend to think not. I don't think it's possible that it will become an endemic disease in China because there's no way the virus is going to stick around. And the reason for that is that there's only a few viruses which actually become permanent infections. The herpes viruses and the retroviruses, and this is not either of those. So if we go back to look at the determinants of transmission in the first slide I gave you, and review it in terms of what we know, those are the things that make me think that maybe things are going to be okay. But I can't be absolutely sure. And by the same token, we can look at these things with that in mind. And it might be worthwhile for you to look at them individually and see what you think. And we can ask questions of what the Chinese CDC should have done. They certainly should have not let the wet market be destroyed. They certainly should have taken samples. If they didn't have time to identify a virus in the samples then, they should have frozen them so they could do it later. And they may have, but they don't give any evidence of that. They don't describe a running tab of how many cases occur per week, only how many cases are found per week. And that's not good enough. And they haven't measured how long cases are feeling well while still infectious, because that will tell us a lot about whether or not infectiousness is going to keep happening. And they haven't categorized the course states by their severity, so we can tell whether or not there are some that are more super spreading than others. And they haven't given us evidence of culture of body fluids and, of course, feces being the most important. And we haven't categorized the cases in contact by the relationship. So we could probably find out how many cases were hospital-based, but not how many were in the next bed or in the next room, which would be an important thing to know. And they haven't tried to actually culture air samples at varying distance from cases. There are so many cases, they certainly could do that if they tried. So some observations are there. One is that the disease pyramid is wide on the bottom with many mild cases. And the question is whether or not those cases are not as infectious as the others, so that many of the transmissions are coming from a relatively small number of cases. And the incubation period should have produced more secondary cases because there were a lot of people exposed before diagnoses were made. So it's surprising to me that there's that little transmission. But it's possible that the virus is very viable under different circumstances. And certainly the circumstance in Germany is very different than that in Wuhan. And I've already mentioned the fact that I was concerned about whether or not the holding pens might have actually made the outbreak bigger. So we think that the X cases will be immune, and the person exposed to the risk in Hubei will be exhausted at some point. And when I say exhausted, I mean the ones that are still free and walking. It's not going to, they're not going to infect. I can't believe that they're going to continue to infect the number of cases per person that has been going on. I think that the susceptibles are going to be eventually exposed. So I think it's going to rapidly disappear. But to be quite candid, I'm the only person that seems to think that, because the World Health Organization and CDC are at least telling people that they think it's going to be going on for a long time. Okay, one more slide. And that is just to remind you that this is one of the big outbreaks in the world, but there are lots of others. And what are the determinants of transmission? What affects the degree to which one person is likely to transfer a virus to another person? And what are the methods of detection of the disease once we've got it? I'm not going to spend any time on that, but I just mentioned it. The methods of prediction as to what's going to happen in an outbreak or with the disease, and the methods of the determinants of pathogenesis, which ultimately tell you how many people are going to die, or whether people are going to stay sick, or what's going to happen. And then, of course, the methods of prophylaxis, if one would be so lucky as to have the opportunity to prevent a person who you thought was going to get sick from getting sick, and then the methods of treatment. And then when we're talking about group populations, epidemics, the methods of control and eradication. Now, most of these I'm not going to spend any time on. I just list them for you to think about. But let's focus on determinants of transmission for a minute. If we have an outbreak that we think is droplet spread, first thing we have to do, of course, is make sure that it is only person to person. And in the context of this particular virus, that means trying to distinguish between people who caught the virus at the market, which is presumably where it started, and people who caught it because they were exposed to somebody else who got exposed at the market or somewhere else. So we're interested in being able to make that distinction. Of course, at this point, a month after the market has been essentially destroyed, it's a moot question. But it's a question to keep in mind at the beginning. The next question is it only droplet we're talking about? And that's a really important question in this context, as we'll see, because SARS was not just droplet. It was droplet, feces, and every body fluid you could imagine that had the virus in it. And so it could spread a lot of different ways. And of course, if it's droplet, it'll means second are at much higher risk than people who are only casually in contact, meaning with air between them. The next question that's pertinent is, when is the virus being sent out into the world in relation to the person's symptoms and the distance from the time that he actually was exposed? So part of that is the incubation period. That's the period between exposure and the first symptom. But that's not the only part. There's probably going to be a few days before he actually starts dispersing virus, even if he's starting to have symptoms. And now the next set of things are usually not considered, but they are really important. And it's something that you have to think about. The person who is the spreader is the exposure. His behavior becomes important. If he is a person who's trying not to let anybody know he's sick, that has a big impact on how many people he exposes. If, on the other hand, he's decided that he's going to be a person who gets a lot of people sick, then he may be trying to do it. And there are people who do both those things. Now, in this case, we're dealing with thousands of people, so it's not that pertinent. But the next part is really important, and that is, how are people trying to prevent themselves from getting sick? You all know that masks are the most valuable commodity in Asia right now. They're simply not available to all people that want them, and that's true in Wuhan as well as in the province of Hubei and the rest of China. Manufacturers of masks are sending them to China in huge numbers all the time, but it's not just masks. Are people scared? And I'll give you an example of that in a second. But if people are afraid and they don't want to go anywhere near somebody, they're less likely to be exposed. And you take that into consideration when you think about what's going to happen. I understand that people are afraid in San Diego County of living in anywhere near a place where a bunch of people have been airlifted and put into storage, as it were, so just in case they might get sick. And that means, of course, that nobody anywhere in any other town is going to be at risk because none of these people are sick and therefore none of them are infectious. But that doesn't stop people from being scared. Apparently, some of the little villages in North China put a guy out on the road with a machine gun to make sure that nobody from any other village came into their village, just because they were afraid of somebody from Wuhan showing up and making people sick. And obviously there are differences between just not wanting to be anywhere near somebody and saying, okay, I can be close to somebody, but not really very close, because intimacy might make a big difference. And of course, the other thing is they have to know who is sick and who isn't, and who's potential dangerous. And then we have to talk about the actual characteristics of contacts. If you are a person who is about to get sick and you get put in the hospital, you can categorize the people that might be at risk. For example, the difference between caregivers, nurses, doctors, hospital visitors, hospital patients in the next room or down the hall, they all have different propensities to actually be infected from droplets that you may be putting out. And then you have to get quantitative about that, not only be able to estimate the number in each category so that you'll be able ultimately to calculate the rate of occurrence by category. And then you have to think about the number of such people in range over time. In other words, if you're in a hospital, if you have a hospital bed with a patient in it, how many people actually are allowed to go in and see him over the course of an hour or two? And then after that, the question is, how many people are susceptible? You may be susceptible because you've already had coronavirus infection, and therefore you can come in without worrying about it or not. And even if you've never had it, you may be more susceptible because you have pulmonary disease of some kind, or congestive heart failure, or diabetes, or any one of a number of things. So comorbidity makes a difference in who might be at risk. And having said all that, which are behavioral and biologic characteristics of both the person who is sick and the person who might be exposed, we come down to how you calculate the effective dose of virions that are being put out. And that's not easy either. And of course, you never can actually do this, but it's important to think about exactly what is going on. Certainly the location on the body that viruses are coming from is important. And in the context of respiratory disease, that means, are they coming from the pharynx, or are they coming from the bronchus and their upper respiratory tubes, or are they actually coming from the lower part? And that depends on which cells are actually infected by this particular virus and whether or not those cells are sick enough to die and put virus out. And there are very big differences between the diseases that I put on that list a few minutes ago as to exactly what happens. Furthermore, there are dose response curves to think about. Now this is more important in the context of chronic disease, but it's still true. If you think that a gram of droplets inhaled in the course of an hour has a certain level of infectiousness, then the question is, what is going to happen if there's only 1/10 of a gram? Well, there are three possible ways to deal with that. Three kinds of dose response curves that are biologically credible, and one has to take an estimate of which one is going on. The default, the easiest one to think about, is that it's a straightforward linear dose response, so that if a gram produces X disease per 100 people exposed, then 1/10 of a gram will produce 1/10 of that number of cases per X per number of people involved. But that's only one of the three. A second potential curve is that there's a threshold that okay, at a certain level, and it goes up for a while, but then all of a sudden, beyond a certain point, it doesn't infect any more people. And that means that the linear part is only the bottom part of the curve. And so you have to figure out what the top part of that line is before you can calculate what's going to happen. And then the third possibility is that it's a plateau, and that is that not that there's a threshold, but there's a certain point at which no more actually happens. But we're never going to actually make those calculations, but they just have to think about it and think about whether a linear arrangement is what you're likely to see. Another thing to think about with droplet disease is there a mechanical, well, no, first I've got the issue of super spreader. Nobody knows exactly why that happens, but the fact is that some people become really effective persons who give disease to others. And that probably means that they're spewing out more variants per unit air, or more variants in the feces, or whatever the method of transmission is. So some people are much more dangerous than other people. I'm not sure what that means. Is that a question? Just a person. Okay, so there's super spreaders, and if there's a super spreader, then danger is much higher than it would be otherwise. And then the thing I started to say a moment ago if you have somebody in the bed who is sick and they have droplets coming out of their nose and mouth, wherever they come from, they go into the air, but after a while they fall down. And if they fall down on the bedclothes, it may be that the bedclothes offer a mechanical vector. And that means that if somebody comes in and rustles up the bedclothes, there's more virions going into the air to be potentially breathed. So it's important to know whether that actually happens if you try to minimize the exposure. And then there's a duration of dispersion, how long people are actually infectious, and when that that period of infection stops. And obviously, when you try to calculate how many people are being exposed by a given patient, then you make an estimate based on how long you think that the variants are coming out in an infectious manner. And then once the variants come out into the air, the question is, how long do they live? Because if they die right away because of ambient temperature and humidity, then it doesn't make any difference. But if they persist for a long period of time, then it does. And then the final issue is, how far are the people apart? If you're a long way apart, you're more likely not to be infected than if you're very close. Okay, so you see what all of the issues are. In terms of pathogenesis, very simply, obviously depends on the location, whether it's an upper respiratory infection or actually pneumonia, and whether the cells that are being infected are just the superficial epithelial cells, or whether or not they're also infecting the immunological cells, which have a much more severe potential. And how many organs have cells that are being infected? In other words, are the infection not only getting your upper respiratory system and your lower respiratory system, but your GI system, and infecting the cells in your bowel, your small bowel, and that obviously makes a difference as to whether those cells are going to be, those viruses are going to be put out in the world. And then the question is there evidence of, in a given disease, of mutation of virus over time? Does it adapt to infecting humans after starting out by being only an infector of birds, for example? So that's another biologic question that one puts out. Now, you may have seen in the media a reference to the letter R. People have tried to make predictions on what's going to happen in an outbreak by using mathematical models, which basically put together information about all the things we just spoke about. See, okay, given that there's going to be virions coming out of a person's mouth, there's going to be so many people per unit time around that person, and the viability of the virus is at some level, we can make a guess as to how many people one case is going to infect in the duration of his illness. And R is a reference to that number. In other words, if the R is 2, it means that the average number of people that are going to be infected by a case is 2. And much discussion of that has gone on in the infectious disease community. Even way back in the 1930s, they made probability models which had the form that is given there, but I won't bother with going through it in detail. But it basically is saying the number of susceptibles times the probability of contact. And so practical R is the reproductive number. The empirical prediction of new cases of the disease, given that one case has already happened. And of course, you have to make assumptions about the susceptibility of the people around. So there's one R for whether people are all susceptible, and a second R for empirically knowing what happens. And so there are studies done to try and estimate what R is in a given circumstance. And people have assigned R numbers to various diseases, and you can see how much they vary from disease to disease. And I would tell you that the bottom estimates of SARS were from 2 to 4, but compare that to measles, because measles is the champion. It's the champion because the virus is much more sturdy, it lives for a much longer time, it goes out much more efficiently, it starts even before there are symptoms, and so a case of measles can infect more people on average than any other of the diseases we're thinking about. And the estimate that is in this paper is 7.1 to 29 people. And 29 is probably, it means what happened at Disneyland that time a few months ago or a few years ago. But you can see that smallpox is 3.2 to 6.9 or whatever it is, and rubella is 2.9 to 7.8. Each of these represents the number of people that would be infected by a given person. But I am here to tell you that none of that is very important. And it is important because modeling is imprecise, that's one thing, but for another reason, and a far better one, as soon as there is an epidemic, things change. And especially what changes is the behavior of the potential contacts. So if smallpox has an R of 2 on a steady state, given that 10% of the people that he comes in contact with are susceptible, and and he is a medium level of spreader, not a super spreader, but that's all off if the outbreak actually gets into the press and people realize that there's danger, because then all of a sudden anybody who's got a pimple is presumed to be a case of smallpox, and the number of people that he comes in contact with becomes much, much less. So you can be sure that predicting on the basis of SARS what the number of people that are going to be infected by this coronavirus is just totally imprecise, because people in Wuhan and everybody else have gotten so scared that they're not doing anything anywhere near what they think might be a case. So it's fine for an endemic disease or a regular disease occurrence. For example, malaria is a disease which this method can use very effectively. And even ordinary flu, seasonal flu, it's a reasonable thing to use, but not when there's an epidemic like this one. And of course, even then, it's very variable because there's heterogeneous susceptibility in all circumstances. The real method of predicting what's going to happen is the old-fashioned, ordinary, main tool of epidemiology, namely surveillance. And surveillance means looking to see what's happening. And with a little bit of knowledge about what you should be concerned about and what the various parameters are, surveillance will tell you what you think is going to happen. And that often comes in the form of an epidemic curve, so you can see where actually the curve begins to drop off and whether or not it's meaningfully dropping off. So surveillance means looking at time, place, and person. It implies always that there's feedback to decision makers, which means the predictors. It requires a very clear definition and a very clear definition of the population at risk. And just to tick off methods of control and eradication, even though they're not pertinent for you at this point, it's obviously case isolation, which is being done everywhere, and it's contact isolation, which means that if somebody might have been exposed, to make sure that they don't expose somebody after they get sick, it's prudent if you can get them to be isolated, even though they're not sick. And that's in theory what's being done to the people who've flown out of Wuhan. Although I don't think it's very warranted in this case, because there really is plenty of time for them to be isolated when they get sick. Maybe it's because they don't think they can trust them, and that's possible. There's community isolation, which is what the guy who's got the gun up in the village in northern China is trying to do. Then there's mass vaccination. It's a disease which you can vaccinate against, which this one is not yet, but maybe will be at about time when it's no longer needed. Mass vaccination is not a very good choice in many circumstances, though, because it takes all kinds of people to actually manage. It's an industrial method, if you will, because you've got to figure out how to decide what the priorities are in vaccination. Otherwise, some people will be mad, and some people who might need it don't get vaccinated. And vaccination for most diseases is not always completely safe, although it is safe for practical purposes, measles being one of the vaccines that most safe. But something like smallpox vaccine is not at all safe in the mass vaccination context, because even though it was a terrific saver of lives when given to people who were likely to be exposed, if children who were vaccinated back when I was a kid, everybody in the country was vaccinated against smallpox. And because smallpox can be transmitted to somebody who has erythema, or because it can even create in very unusual circumstances, neurologic disease, we were actually killing one person for every million people that were vaccinated as children. And we actually made a big campaign to stop that at one point at CDC, which we did successfully. And what protected the country was not mass vaccination, in fact, but the requirement that people who came into the country had to have evidence of a vaccination that was still good. And because of that, nobody could bring smallpox in, and we were protected as a nation. And Europe, as I'll tell you in a minute, was not that safe. When we as a nation set out, we as a community, world community, set out to eradicate smallpox, what was done was not mass vaccination, but ring prophylaxis, which means identifying exactly who was exposed, isolating or making sure they were protected if they were at risk of exposing somebody else, and cutting the chain of disease that way. And in effect, that's what most places outside China are trying to deal with in this case. They're trying to make sure they identify everybody who might be exposed and make sure that they don't in turn infect somebody else if they get sick. So this is a graph that I put together for your consideration, which just discusses each of those diseases and points out some of the differences between them. As I said before, measles is a disease which comes from the pharynx and your skin, and unfortunately it's unique because it can begin infecting before there are any symptoms. Is there any mutational drift? No. How long is the disease still infectious? Till the fourth day of the rash. So we can actually make a pretty good estimate of when somebody's no longer infectious. Does it live in ambient air? Yes, it's extremely stable, and it can not only project linearly one from a person's cough over a fairly long distance, but it can stay alive in the air and be breathed and infect somebody who's not even close to the person at the time that the cough happens. Then we go to seasonal flu, which you're all familiar with. That comes from the upper respiratory tract. It obviously produces upper respiratory infections, symptoms. Is there evidence of mutational drift? Yes, and that's why we have to get vaccinated every year, because new strains of flu that have been identified and are expected to show around. And its infection till about the 10th symptomatic day. The ambient viability in the air is high, not as high as measles, but it's still high, and the projection is pretty far. So you can catch flu from somebody even though you're not really very close to them. Then we talk about the 1908 flu, and this is mostly conjecture, but it's pretty well based. It's obviously coming from the same place in the upper respiratory tract, and people had the same kind of upper respiratory symptoms. And was there mutational drift? Yes. That's why we're afraid of it coming back. And it's going to be like seasonal flu in the other respects. Yeah. So the third kind of flu is bird flu, and that's actually been there are several kinds of bird flu in terms of the combination of the H antigen and the N antigen that make up influenza, but also comes from your upper respiratory symptoms, and there's obviously drift and stays infectious for as long, but its ambient viability is relatively, actually it says high. We don't know whether it is. It might be low, but it looks as though, empirically speaking, that you have to be very close to a person with bird flu to actually get infected. So even though there's been fear and people have demonstrated that it can spread person to person, it mostly spreads between members of the same family who obviously are sharing a lot of things in common, including viruses. So it's a little bit different kettle of fish than the other influenzas because it doesn't, probably because it doesn't spread quite as far. And that may be because it has less adaptability to human cells, having been raised on bird cells. Okay, then we come to smallpox. And I mentioned smallpox, obviously, because if I have any credibility in talking about epidemics, it's because I spent a lot of time studying the epidemics of smallpox. And it's of interest because it's something that scares people to death. But in fact, I think it's something of a paper tiger. It was no question that you could kill people by infecting them with smallpox because the case fatality rate was about 25–30%. But the fact is that the incubation period is a full 2 weeks. So in terms of trying to prevent further cases, you have plenty of time to identify who's been exposed and get them isolated. And so you could pretty much be sure that you could stop an outbreak of smallpox within a couple of smallpox generations, which means a month or two. And that's pretty much what's been done historically. Every place there has been smallpox with thoughtful people interfering. But it shows is if you want to catch smallpox, you've got to be relatively close. And I'll show you data in a second that under circumstances that we know about, the people who get smallpox have been people in the hospital or people in the same family of that. So they've been relatively intimate in contact. And because that has happened, I mention it in this context, and the question is this virus behaving the same way? Because if it is, the more likely that it's going to die off eventually. Okay, now we come to SARS. Now, SARS has two characteristics that are different from smallpox. One is upper and lower respiratory tract, and the actual virus actually did infect the immune cells of the body. And it also infected the epithelial cells of other organs, and in particular the GI tract, so that the feces was infectious. And that means that there's a whole other ball of wax in terms of how to make sure you're preventing people from getting infected. And it was usually lower respiratory tract symptoms, meaning pneumonia, and there was drift, and the duration of dispersion was at least 4 weeks after the first symptom. It had relatively high ambient viability in the air, and it went fairly far away. Then we have the next coronavirus, MERS, the Middle Eastern respiratory virus, which is similar to SARS in most respects, although it stays infectious a bit longer. It did not involve the lower respiratory tract, and it only infected people that were relatively close. And it had one other difference, in that it killed a lot more of the people it infected. The case fatality rate for SARS was about 10%. The case fatality rate for MERS was over 30%. Well, now we have the new virus, and we don't know some of the things about that. We can presume it's upper and lower respiratory, and that's the kind of symptoms we're dealing with. And we can predict that there probably is, well, there might or might not be low viability in the air, and might or might not have to be near. So those are questions that we have to ask. And we don't know anything about the duration of exposure or about the mutational drift. We hope that if it is, it's not making it much more deadly disease for human beings. This is just to remind you what measles look like, and we've already discussed how infectious it is, and much more infectious than any of these others. And this is to show you what smallpox looks like, and to tell you why we don't like the idea of having to deal with it, even though it's a paper tiger in some ways. This is a seasonal distribution of smallpox in West Pakistan when I was working there, which shows one potential fact that I've mentioned before, and that is viability in the air. It looks as though during one season, people didn't get infected very efficiently, and that was, in fact, very true. During the monsoon, when the air was very humid and it was very hot, the virus didn't survive in the air. Well, I'm conjecturing, because cases didn't get infected nearly as efficiently as in other times of year. I don't have any reason to think that coronavirus is the same way, but it's a fact of interest. And this is another piece of smallpox history that is relevant, and that is the difficulty of knowing on a population basis which generation is which, and whether people got exposed by somebody in the previous generation or in their own generation of disease. So all we could do is look at, we actually could identify who the first person in the outbreak was, and then look to see when the people who that person infected showed up. And you can see that the things were not terribly smooth. You couldn't tell some people from the date of their diagnosis whether they were part of the first or the second generation. And so to try and calculate a rate of occurrence after exposure was not easy. Because we knew that smallpox didn't spread very efficiently, we could be interested in seeing how long outbreaks actually lasted. And it turned out that after somebody brought smallpox into a village, about a quarter of the time, nobody else ever got it. And about a third of the time, only one new generation occurred, and it stopped after that. And if you go down to the last line, it's basically, even though people in the villages were susceptible, there was only one outbreak over 15 years. Now that means a terrible disease, but a terrible disease, it stays around even though it doesn't last very long in a given place. So it has to take a global strategy to make sure you eradicate it. And we might be dealing with the same sort of thing. And this is to say what the characteristic of the person who's infected is important, why it's important. This is all of the outbreaks which came into Europe from 1950 to 1975. And there were 51 importations from either South Asia or Africa. And it caused an average of 18 cases each. And 20% of the people who got sick were household contacts, in other words, family members. 9% were other close personal contacts, like a close work contact or a best friend. 25% were caregivers outside the hospital, and 40% were hospital patients and visitors. And only 6% had no known contact, and that means that we didn't learn about, nobody learned about the contact, but they may actually have had one as well. So the man on the street is not very likely to get sick. And from looking at the behavior of this coronavirus, it may be that that's also true. That it's mostly people who are fairly intimately associated. But that remains to be seen. That's strictly a hypothesis. Okay, now you knew about this. In 2003, a doctor from Guangdong stayed one night in a Hong Kong hotel, and partly because his feces went on the outside of the hotel and dropped down to other rooms, he transmitted an infection to 16 other guests in the hotel, who in turn seeded outbreaks in at least 4 cities, and then ultimately 25 countries on 5 continents. So about 8,000 people worldwide got sick with SARS, and 774 of them died, which is roughly 10%. In the US, there were 8 laboratory confirmed cases. And after the outbreak of SARS stopped, there were a couple of cases that popped up in laboratory workers or in people who worked in the food industry in Guangdong. It was learned to be a large RNA virus like this coronavirus, and it was found in bats after people checked. It was recovered from anal smears and horseshoe back in China by PCR, by molecular means. And genetic recombination allowed for human infection and went from animal to person and person to person, spread largely at the bedside, just like smallpox was, high risk in the hospital, infected cells in multiple organ systems, not just the respiratory tract. Only unusual circumstances that go beyond, that means beyond the hospital. The children are very low risk, and nobody really understands why that is. It may be because coronavirus of the other kind, the kind that produces a cold, is much more common than we think it is, but nobody knows why. Super spreaders were occasional but not common. And if a person was asymptomatic or pre-symptomatic, they were not infectious. This is the bats hanging in a cave, probably in Malaysia. But the horseshoe bat has a horseshoe-looking face. The bats are kept in the market and sold as food. And together in the market with the bats, are other animals, and the one in particular where the virus was first isolated was a civet, which is a member of the raccoon family. I think maybe is a member, probably a member of the ferret family. The masked palm civet was the civet in question. And then there's another animal, it's like a civet, called a ferret badger, and then a raccoon dog. All animals totally unfamiliar to us. But when they began to isolate viruses, they isolated from all three of those mammals in this wet market in Guangdong. One of the places that SARS first went was Toronto, and it was a very informative epidemic because one case showed up in the emergency room. That was the son of a person who had been sick with pulmonary disease, and it turned out to be that person who was the mother of the person who showed up in the emergency room had gone to Hong Kong. So got transmitted from the doctor to that person, that old lady, and she transmitted it to her son, and her son came into the emergency room. And over the course of the next month, 128 cases, 46 hospital staff, and 36 patients and visitors. And almost everybody in that emergency room came down with SARS. So this was a disease that didn't require absolute intimacy, but it just had to be within a few meters of a known case. And in the second hospital where it went, because people who had been discharged from this hospital were admitted to another hospital, it infected all cases and patients on the ward, and only 8 people were on the same ward without a case. So it got transmitted between wards in some way, but for a relatively small number of cases. And nobody outside the hospital got sick. So this was a good lesson because in Toronto, it's clearly shown that even though you didn't know what the virus was, you didn't know whether there was a vaccine, you didn't know how it spread, just plain simple classic public health, surveillance and isolation did the trick. Within a month or two, the epidemic was totally gone. So SARS left its way 8,000 cases in 24 countries on 4 continents, 11 U.S. travelers, but no deaths, billions lost in airlines, tourism, worldwide economic downturn, and devastated the healthcare system, all of which is familiar with what's going on right now. These are basically the things I said a minute ago. No assays, no risk factors, no treatment, no agent, no knowledge of virus origin, and not very well-defined infectious control practice. But despite that, the virus was identified within 5 months, diagnostic tests developed, infection control practices established, international public health worked, surveillance programs set up, and in 5th of July, the last region was taken away. And my prediction is that that's probably going to happen, but we'll see. Then we have MERS. It popped up in Saudi Arabia, and it truly does seem to be an infection of dromedary camels. Now, I hate to say this, but whoever made this picture and this slide thought a camel was a camel, because it's not. That's not a dromedary camel, that's a non-dromedary camel. A dromedary camel is the kind with 2 humps, and it's the kind that makes it very easy to ride. But anyway, this particular coronavirus appears to be resident in camels, and it's postulated that it might have come sometime from a bat, but there's no real evidence for that. And camels all over the Middle East have been shown to be infectious. In fact, camel herder after camel herder after camel herder has shown up in the hospital and been diagnosed. And there have been multiple small outbreaks throughout the Middle East, and they've been actually a bit more serious than SARS. More people died, 35% roughly, but no fecal contamination at all, just droplet. So that shows that coronaviruses come in at least 2 times. And the most notable thing about the MERS circumstance was what happened in South Korea, where a 68-year-old man returned from visiting South Korea, and over the course of 2 months, in multiple hospitals, 186 cases and 38 deaths from MERS. 24 different hospitals exposed in 7 cities. And the worst thing that happened was that the public health people in South Korea did not make it public, so people didn't know what was going on. And that means a lot more cases occurred than would have ordinarily. And it was a hard lesson they had to learn. So this just shows, again, what happened. Guy infected his wife and visitors in the rural ward. And then people went to other hospitals and infected other people. And this is what a wedding in South Korea looked like at the time that MERS was going around. And this is the epidemic curve of deaths and cases in South Korea, and the red line being deaths, and the yellow being attempts at quarantine.